I want to welcome everybody to our 8th session of the Learning Collaborative for this year for the PCMH. As a reminder, let's with the next slide. Please mute the phone when you're not speaking. This will eliminate any background noise, but please do not put your phone on hold, because if you do, we will start hearing your hold music, and we've done that before. Next slide. We've got a pretty busy webinar for today. We're going to start with AAP report, and I'm going to give folks some updates on shared savings and re-enrollment. We're going to talk about data reports and collection, and if we have some time at the end, we'll talk a little bit more about profound knowledge, which is a concept that really helps put looking at a problem to address for quality improvement in perspective. It's just a good set of tools to know. Next slide. The disclosure is that support for the webinar is provided by DHS and Arkansas Medicaid. Next slide. And we're going to skip the roll calls for this time, just because we want to try to get everything done before we run out of time. So this is an overview since it is now September. The next set of metrics to meet are going to be the 12-month metrics, which are not due until December 31st. At that time, you'll see a few metrics here. There is some short survey related to patients' ability to receive timely care, appointments, and information for specialists. We will be asked to document our approach to contacting patients who have not received preventive care, document that there is an investment in healthcare technology or tools to support practice transformation, and there is a requirement to join SHARE to get inpatient discharge information from hospitals. Now, we will actually be talking much more about SHARE next month. We will have another presentation on SHARE at our in-person Learning Collaborative meeting, which I hope to see many of you there. Next slide, Kristen. So now that it's September, I want to remind folks that if you haven't seen your Q3 data report, which we'll go over in a little bit, make sure that you take a look at your Q3 data report. That is there now. But also get ready for the 12-month deadline, which is coming up on December 31st. Of course, we always want to know how things are going, and we want you to always keep in mind, how do you know that you're making changes in how care is delivered and received by our patients and families? Next slide, Kristen. Amy, I'm going to turn it over to you to give us an update on Medicaid and our contract activities, as well as any updates we have on our discussions with AFMC and Qualis Health.
Goodness, this is Kristen, and I'm not completely positive Amy's on here because there's a lot of things that say call in user 5, 6, 7, 8, 9, but I'm not exactly sure if one of them is Amy. Amy, are you on? She might not be.
Okay, you know, I remember that you're listed as Amy since you've plugged in. Okay, okay. Kristen, do you have any specific updates? Yeah, actually, I don't want to so much put you on the spot, but you might more know about what's been going on with those meetings than I do.
I do, but a lot of what I have been hearing about, you're going to be discussing in the next slides. So I'll
okay.
Keep going.
Okay, then we will be happy to move on. Okay, next slides. I want to take some time to talk about the distribution of shared savings, or the calculation of shared savings, because that is something that will be addressed as we go into the next calendar year. Next slide. So the concept of shared savings is that if providers right now are being held accountable for the total cost of care with some adjustments for their patient population. So we're getting upfront shared support, we're getting upfront payments for practice support, practice transformation, and care coordination. Any savings that are realized by bending the cost curve will be returned. We become eligible to have some of those savings returned to us. So providers will be rewarded for performance and quality and cost of care through shared savings. So anything that is saved by Arkansas Medicaid through our work, we will become eligible to share in those savings. Next slide, Kristen. There are two ways, just as a reminder, there are two ways that Arkansas Medicaid may calculate shared savings. So the first way is that there are statewide cost thresholds that you can meet. That is if your practice costs in a performance period is lower than the statewide cost threshold. So that is beneficial to a practice that is already performing at an efficient level when it comes to healthcare expenditures. The second way, which is option B, is that the practice manages growth of costs. And that means that a practice is compared to itself, and this benefits a practice if your benchmark costs are already lower than what your performance period costs are. So in other words, if you historically have had a practice which has cost on the higher side and you can't get down to the statewide cost thresholds immediately, this still enables you to generate shared savings based on your historical performance. So if you are able to control your gross and costs, then you can generate shared savings. So practices, of course, must meet benchmarks on quality in order to be eligible for shared savings. And incentive payments are, however, based on a greater of the two payment calculation methods. Next slide, Kristen. This chart shows shared savings incentive payments. So this really goes under option A. And the way that Medicaid is choosing to address shared savings is looking at the historical averages of all the practices that are participating and looking where the high cost thresholds are, medium cost thresholds are, and low cost thresholds are. There is a cost of care floor, which means that there are no shared savings that are additional if your cost of care goes below that floor. And what that means is that we won't be rewarded for not providing care at all. We have to provide a minimum of care. But if you are below the medium cost threshold, you would get back 50% of your difference between your average cost and a medium cost threshold. So in other words, if the median cost threshold is, say, $2,000 per patient, and your your average cost is $1,500 per patient, that's $500 per patient saved, and they would give you back $250 per patient. Next slide, Kristen. Now, under scenario B, you again get a, as a reminder, option B, if you are managing your growth in costs, you are therefore compared against your historical average. And if your benchmark cost, which is represented by the solid line, if your average cost is below your benchmark cost, you get a percentage of the shared savings between your cost and the benchmark cost. And that can range between 10 and 50%. If your benchmark cost is relatively high, your shared savings is going to be closer to the 10% mark. If it is lower, it's going to be closer to the 50% mark. So the bottom line is that the shared savings is going to be between 10 and 50% of what Medicaid saves, and they will give you between 10 and 50% of it back. Next slide, Kristen. There are requirements, quality metrics, to participate in shared savings. The first is that, as we know from pooling of practices for this year, you have to have at least 5,000 attributed beneficiaries for at least 6 months. You have to meet practice productivity and milestones, and you've got to achieve quality metrics. So if you make it through the 12-month point and you've met all the practice activity milestones and metrics, you also still have to achieve the quality metrics in order to be eligible for shared savings. And for the most part in pediatrics, that really comes down to the 3 quality metrics you see in front of you, which is your rate of health supervision visits over the past year, as well as there's a measure for appropriate use of asthma medications, and then there's a measure for seeing children with ADHD and follow-up after initiating medications within the first month. There are other measures that you'll see on your practice report. The vast majority of them will have no application to pediatrics. That includes things like the beta blockers. You also may not have enough patients who are on thyroid medications, and that's, for example, another measure for shared savings. Next slide, Kristen. I want to reiterate that it's a good idea to take a look at your data report and think about where your opportunities for savings are. So first, when you think about shared savings, take a look at your eligibility. Make sure that you are meeting your 12-month metrics, and also take a look and see if there are metrics, your shared savings metrics, that you're not meeting and need to address. So if you're, for example, your appointments for adolescents are not high enough, then you need to make sure that you're implementing PDSA cycles to address that. Then make sure you take a look at your data report and look for outliers in cost, because what Medicaid's data reports have done is break down all your data to the point where it's looking at service lines as well as children who actually use those services. Now, the data is historical, and we'll discuss in a little bit that because the data is historical, it may reflect data that's about 6 months to a year old and may not necessarily reflect what you're doing now. But it is a start, and if your practice patterns haven't changed dramatically in the last 6 to 12 months, it's still a very good indicator of what's going on. Next slide, Kristen. So let's take this sample chart for a minute. In this, you'll see in the left-hand column, you'll see that the number and percentage of beneficiaries who have claims in that particular category. So you'll see that there were various care categories in your report, ranging from outpatient professionals to pharmacy, the emergency room, to outpatient labs, inpatient professional, and going all the way down. And you'll see, for example, in this sample that 100% of your patients in this sample use an outpatient service in the last 12 in the reporting period. However, if you look at the dark blue versus the light blue bars, the dark blue bars would be you, and the light blue bars would be the average for your risk cohort. So you'll see going down the line that for this particular set of data metrics, that this particular practice, all of the patients are already coming in for outpatient professional visits, and they're actually relatively inexpensive visits, so they're not spending a whole lot of time in outpatient professional visits. However, this particular data report shows that there may be shared savings opportunities on pharmacy costs because their pharmacy costs are relatively high compared to their risk cohort.
Yeah, I got it working.
And this practice has relatively higher costs in the areas of inpatient professional fees, outpatient labs, and emergency department costs. So those are areas that you would want to focus on if you are this particular practice. Okay. Next slide. When are shared savings going to be determined? The most recent information that I have heard from Marcus on Medicaid is that they will likely be calculating and dispersing the shared savings in quarter 2 of 2014 at the earliest. And the reason it's going to be that quarter 2 as the earliest is because they want that 90-day run-out period to be able to get all the claims dating all the way up to December 31st, 2014. Therefore, the earliest that they can really look at the potential for shared savings is quarter 2 in 2014. What they are also thinking about doing is dispersing an initial round of shared savings payment, a good chunk of the shared savings, in fact, but not to finish reconciling, but in order to give them a chance to reconcile all the data, they're going to reconcile all the payments, and the final determination of your total amount of shared savings for 2014 may not actually come until the first quarter of 2016. So the bottom line is to really look at it, is to look for the possibility of shared savings disbursement in the second quarter of 2014, I'm sorry, that's a typo, 2015, along with a final payment by early 2016. But the intent is to distribute as much of the shared savings as possible in the second quarter of 2015. Kristen, next slide. How does the practice risk score impact the shared savings payment? It is possible that your per beneficiary cost of care would be adjusted by your practice's risk score as birth of your patients require additional resources. So just keep in mind that your risk stratification may actually change or impact your shared savings incentive payments. Okay, questions about shared savings. Questions about how they're calculated, when they'll get dispersed, how to look at your data reports for shared savings management. Okay, Kristen, let's go on to the information on re-enrollment. So we're now we're now looking at the re-enrollment period, and next slide, Kristen. The re-enrollment reminder, enrollment for 2015. We have to re-enroll our practices every year, so the enrollment period is now, and you may have already received the re-enrollment package. It's actually much easier than before. Current PCMH practices are required to re-enroll. Please first make sure that your participating physician's information is up to date. If you have new contact leads, it's important that you also update this in the new re-enrollment forms, and that'll be submitted to HP. Next slide. A couple of things that are going to be new in 2015. The first is that practices may pool with any number of practices to determine a shared savings entity. So the minimum to participate in PCMH was that you have to have 300 attributed beneficiaries. But to get shared savings, you have to have 5,000 beneficiaries. Now, this year, so calendar year 2014, practices could combine, for shared savings purposes, practices could combine with one other practice. In 2015, you may pool with any number of other practices. You could pool with one other, you could pool with 5 others. But you have to just get 5,000 threshold. Otherwise, there is a statewide pool being formed this year for savings. So the bottom line is that everybody is eligible for shared savings in 2015. I have listed here several resources are available for practices that are currently enrolled. You can also talk to your AFMC provider reps for other practices that may be looking for partners in shared savings. Next slide. So this is what the form looks like for the re-enrollment agreement. You'll see the a request for primary and secondary contacts. Next slide. This is where you add your physicians that have not been in the PCMH in the past. Next slide. And there's a form to withdraw physicians who are being withdrawn. please remove the physicians that have left your practice in the last year and therefore need to be taken off the PCMH list. Next slide. You will also see when you re-enroll, when you go into the portal, a list of physicians who are currently enrolled. Next slide. And I think that's it for re-enrollment details. Are there questions about re-enrolling? Okay. Let's go on. I'm going to talk a little bit about data reports, and then we have a guest speaker, Lori from the Mercy Pediatric Clinic, and we're looking forward to hearing her reports and her thoughts. Kristen, next slide. I want to discuss the use of data and data reports for a couple of minutes. This you'll recognize is what your Medicaid data report looks like, and you've got the cover page and you've got the PCMH report overview page. Next slide. Then you've got metrics in there which take a look at your specific measures. Like, for example, this is your shared savings metric, which looks at the percentage of beneficiaries who are up to 15 months old with at least 4 well visits during the first months of life. Next slide, please. Then you get your thresholds, your benchmarks, and your cost. This looks at your average cost in 2013 as well as your target cost for 2014, which is used to calculate your benchmarks for shared savings. Next slide. Kristen? And then finally, if you're looking at opportunities for shared savings, there is this particular slide that I presented earlier. And Kristen, next slide. The reason to bring all this up again is that when you're looking at data reports, it's important to understand that there is going to be a lag between when these data reports there is going to be a lag between claims and patient encounters and when you get these data reports. So the most recent data report that we all received this month, the Q3 data only goes up to March 31st, 2014. So your metrics are right now, the metrics that you're seeing are based off of data that are no more recent than 6 months old. It's also important to recognize that when you're looking at data, you're looking also at the calculation of rolling 12-month averages. So, Kristen, if you can go back a couple of slides. Okay, so take a look. One more slide, Kristen. So take a look on the right side. You will see rolling 12-month performances. You'll see the right-hand data point is April 1st, 2013 to March 31st, 2014. But if you look at the data point before it, it's January 1st, 2013 to December 31st, 2013. And then you go back further and you'll see, again, rolling 12 months averages. So this has a couple of implications for us when we look at data. The first implication is that there's always going to be a lag, and therefore what you did in the last 6 months are not going to be reflected in the report you get this month. The second is that rolling 12-month averages means that you're going to have a relatively long period of time where you're going to put data into these data points. And these data points also overlap each other. Therefore, if you did something really awesome during the last 6 months for 2014, your data point is going to reflect the first 6 months when your performance may have been less than what you would have liked. Therefore, the full results of the full impact of your good work may not show up in these data reports for quite a while. Now, there are good reasons for why these data reports lag and also use 12-month rolling averages. They lag because it takes time for the data to be built into the system. There's a 90-day run out period for getting claims finalized. And with regards to the 12-month rolling averages, the 12-month window means that the data is going to be a lot less sensitive to outliers. So what you see is what you get over a 12-month period. Next, Kristen, let's go back 3 more slides. 1 more slide, please. Forward. Yes. Okay. Back. Go forward 3 slides.
Sorry, do you mean forward 3 slides or back?
Go to the slide that says Know Your Data Reports.
Okay, I'm trying to remember. Okay,
there you go. Okay, great, thanks. So, so the data reports from March 31st, 2014, which is the one that we got today. Obviously, they're dependent on when the claims come in. They're dependent on data cleaning, which is what they have to do. Now, we have heard the question about whether Medicaid will provide us with patient-level data. There have been discussions about making that data available on request. And the way you do it is that you have to discuss this with your HP service desk, and we can help connect you if you're interested in that. The latest I've heard is that they are considering making cost data on individual patients available during the 4th quarter of 2014, and metrics will be available in the 1st quarter of 2015. The catch with this is that they're concerned about getting too many requests for individual patient-level data, and they're warning us that because of the volume of requests that they may get, as well as the cleanliness of the data, because it relies on the claims coming in, and the fact that the claims are going to be historical and lag by several months, I think that in the end, the impact of having raw patient-level data for Medicaid is actually going to be somewhat limited. And because for performance feedback reasons, for internal PDSA cycle reasons, and also for audit reasons, there is a big place for you to be able to produce your own data, whether you use your EMR, your business folks, or whether you just collect your data manually, doing some chart audits at a time. You need to be able to collect your own data to be able to help you make changes in your performance. So with that, I'd like to turn it over to Lori. Lori, are you there?
Yes, I am.
Okay. We're going to give this over to you for your time, and we appreciate you taking the time out today to present your thoughts on data.
Sure. Just briefly, Mercy Northwest Arkansas is a series of 22 clinics, hospital, and a convenient care clinic, and soon to open a freestanding emergency room in another another city in Bella Vista. So when we applied for patient-centered medical home, we rolled all of our primary care clinics up under pediatrics. So we really have adult Medicaid as well as children. So we have all the quality measures that we're trying to deal with. Mercy is taking the position that we want to treat all patients the same as far as population management. And so they've developed a series of reports that we use regularly to identify gaps in care and be able to address them. These reports initially have been built for Medicare because we're going to apply to become an ACO January 1st, but we use them also for pediatrics. There are some gaps in the PEDS data like immunizations and so on, but it's very helpful to have real-time data to see at any one time where you are. Let's go to the next slide. I'm not really sure which one's first. Obviously very tiny, hard to read, but this is a patient, let's see. Yes, I've taken the patient names off, but this is a patient-level detail report. We can run this report at multiple levels, from patient level by doctor all the way up to whole community. And we call it a Go Green report. So every patient that's attributed to a PCP has all of these measures, and I'm sure you can't see it, but it tells who their PCP is, when their last visit was, when their last either annual wellness visit for Medicare or Medicaid well-child visit, if they have any emergency room visits, hospitalizations, if they have certain diseases like diabetes, when their last A1C, their last LDL, all the measures that are attributed to that. So every PCP gets this report for all their patients each month. Let's go to the next one. This is a roll-up view of one clinic, and we can run this report by payer, by measure like 5-star or ACO or CPCI or HEDIS, slice and dice it any way we want so that we can narrow it down and really identify, what population we want to work on. But based on whatever measure, this one was run with all the measures, so it's got lots of stuff on it. But if we were to just run it by 5-star or just by ACO, it would tell us how many patients we have in each category and what % of them are meeting that measure. Let's go to the next one. This is probably the most valuable tool. This is our daily visit planner. So every patient that has a scheduled appointment, this prints 2 days before for the primary care clinics, cardiology and endocrine. And we print it on color printers. We can also access it through our electronic medical record, but it's valuable to have that worksheet ahead of time so that MAs or nurses can review it. They can kind of tee up some things that are due. Mercy has built a huge number of smart phrases in our electronic medical record to be able to document plan of care for blood pressure or BMI, to be able to do depression screens, fall risk, all of those kinds of things. So the upper left-hand corner really deals mostly with the preventive gaps in care, and then based on whatever disease they have, they'll show in red any other gaps that are out there for that patient. So that's my quick overview. This tool, though, the Daily Visit Planner, is very, very helpful because for the things that the MAs and nurses can do as they're rooming the patient, this tees it up for them and they can take care of those things so that it doesn't all fall to the doctor.
Laura, this is Dennis Quo, and I think that daily visit planner thing is really neat. What was the planning that went into? Do you have some thoughts or background knowledge about what the kind of planning that went into producing this document? Like, did somebody have an idea one day and there was a work group that put this together, or do you have any insights on that?
This was at the corporate Mercy level. It was just recognized, as you were saying, the data is old that we get from claims and from payers, and we wanted a way to have a more proactive, real-time way to address gaps in care as we're seeing the patient instead of always trying to call them back in or trying to, work from the back end. So we have an integrated patient database that takes information not only from our electronic medical record, but from like Social Security death files and downloads from the health department immunizations, all of these different things, kind of like Share is going to be, and puts it all together. And these are produced rather out of our integrated patient database rather than our electronic medical record.
Great. And one other question for me is, how do you have like a team approach or a designated person that reviews these reports? Can you just kind of walk us through how these reports are used on a daily basis?
In every primary care, cardiology, and endocrine clinic, these are scheduled to run 2 days before. In some of the primary care clinics, they have lots and lots of same days. They run the day before. So they go to every provider's nurse or MA, and they review them and kind of circle or highlight and just kind of have in mind, what they want to make sure gets accomplished. If there's a lot of gaps and the patient's coming in for like a same-day sick appointment, then they know they need to have them come back in for a more physical type appointment. So it's really pre-planning for the visit.
That's great. Thanks. Folks, questions, other questions for Lori? Reactions, thoughts?
Holding on this. You'll recognize Dad used to work in the area list too. I'm trying to figure out when she got diagnosed because I've never seen it before.
Going once? Going twice? Any? And make sure that if you're asking a question that you're not on mute. Okay, Lori, thanks again. I really appreciate it. That was fantastic. And Kristen, let's move on to the next part of the presentation. I want to take a few slides and talk about a concept called profound knowledge. And the reason that this is a really nice concept, or just a few few slides to wrap your mind around, is this is something that gets discussed in the quality improvement world quite a bit. And it's a way to think about, it's a way to approach a problem or an issue to be resolved. It's a way to think about the kinds of activities or PDSA cycles you need to implement in order to address a problem. So for the concept of profound knowledge means what kinds of knowledge allows us to develop, test, and implement changes that result in an improvement. And bear in mind that an improvement is something that you need to be able to quantify and be able to measure so that you know that you've made an improvement. Kristen, next slide. So why is the system of profound knowledge interesting, relevant, or important? So profound knowledge enables you to understand where to examine for changes in practice delivery. And when thinking about a practice delivery component, you actually need to address all four components. And the four components of profound knowledge are systems, variation, psychology, and knowledge. And we're going to go over all four of these very briefly. Kristen, next slide. This comes out of one of the fathers of quality improvement. The guy's name is W.E. Deming. And Deming really became famous looking at quality improvement and actually looking at how things were developed in the United States. And then the Japanese auto industry actually took a lot of his understanding of quality improvement and profound knowledge and implemented them into their industry, which explains in large part their reputation for quality that developed in the 70s and 80s. So the first concept is appreciation for a system. And what you need to do is understand that your problem or your system or what you're looking at is a network of interdependent components with a common aim. So you have to appreciate that there's multiple components to any issue that you're trying to address. Number two is that you have to have your knowledge of your variation. You have to know where your basic processes, your work processes are stable or when they're unstable. So for example, an unstable process might be if you look at something and it turns out it was done on a holiday or when a doctor was on vacation, then that's unstable. The third is that you have to develop a theory of knowledge. And what that means is that you have to take chances and predict and anticipate what will happen if you do something, if you take a certain action. This is the very essence of a PDSA cycle, which means that you can't be afraid to test something, try a small change, and learn from it, and use that knowledge as you produce your next change. Your fourth component, which is arguably the most important one, is the psychology of individual, society, and change. And when you address any sort of change in a practice setting, any sort of change, you need to address the human side of change. What's my colleague's motivation? What's my colleague's understanding? Are they having a bad day? Are they having a good day? You really need to understand the human side of change. Kristen, next slide. The basic message from W.E. Deming is that the cause of inefficiency and poor quality is the system. It's not the employees. It is management's responsibility to correct the system in order to achieve desired results. Next slide. So the system for profound knowledge, to review, is systems means understand your systems and apply systems thinking. Think about the components that go into a problem. People means that you remove barriers. You have to be able to work with people, understand the psychology of human behavior, but motivate people, remove the barriers to doing good work. Lower right-hand corner, variation. You have to measure progress, but you also have to use statistics to be able to look at your variation. So that if there's variation between providers, you want to be able to control that variation as much as possible so that you can have predictable results so that you know what's coming next. The fourth in the lower left-hand corner is knowledge. PDSA thinking. You have to be able to test changes. You have to reflect on what those changes did, and you have to use that knowledge that you gained from trying a change and plan to improve with a new cycle. And it becomes a series of cycles, a series of PDSA cycles to improve when you make your improvement. Next slide. How can this be applied? And so I'm giving you one example. So you have your measure of 3 to 6 year well visits. You have to get it up to 67%. You're at 60%. You've already tried reminder phone calls, you've tried reminder phone postcards, and people just aren't showing up. So you want to use the system of profound knowledge to think through the components of what you need to address. So this is really all about taking a step back and thinking through a problem to come up with solutions to try. Kristen, next slide. And so here are some examples. Under systems, you have to think about not just the fact that patients need to show up for their well visits, but think about the other components about what goes into having a patient actually show up for well visits. So what's your waiting time for appointments? Is your system to the point where it makes it difficult to try to get appointments when your patients want to have appointments? Are the hours convenient for parents? Under variations, do all providers follow the same routine to schedule appointments? Is everybody scheduling appointments 12 months later after they come in for the 2-year checkup? Or are some people forgetting? Knowledge. Try new things, try different things. You don't know how something's going to work until you try it. What would happen if you use text messaging reminders? What can you learn from that? How are you going to try text messaging reminders? How many patients are you going to try it on? How are you going to measure the outcome? And what will you learn from that? And what will you try after that? Psychology. What is the buy-in and the barriers for staff to try something new? You know, are people enthusiastic about trying something new? Are people frustrated? Do you have mixed messages being sent from staff and providers? And if so, what's behind those mixed messages? Kristen, next slide. Are there any questions on the theory of profound knowledge or how it can be useful? Okay, I'm going to turn the rest of this webinar over to Kristen. And actually, if Amy is on, Amy, are you on?
I am, yes.
Okay. Yeah, we skipped over your slide about earlier about any updates you have on the Medicaid contract activities, as well as anything with AFMC and Qualis. So if you're okay with giving an update, I'd like to turn it over to you.
Sure. I'm not sure I have much of an update since our last webinar. We're, in, I guess, the 3rd month of our contract with Medicaid, and I think just, maintaining that communication with them and having that seat at the table has been significantly helpful for all of us to provide information to the folks that we're working with on the provider side. Qualis, I know, turned in their application in response to the RFQ to be the practice transformation vendor for 2015. I think that there were a few other vendors that also submitted applications. I know that was heard at legislative review a couple of weeks ago. and I don't know what was decided as far as who's going to be eligible to be a practice transformation vendor that's approved by Medicaid. But I do know that Medicaid would like for more than one option to be available to providers to use for practice transformation. So aside from that, I think that's about it. Dennis, can you think of anything else?
You might have had to skip off to another meeting. I'm not sure if he's on here anymore.
I'm still on. I don't have anything else to update other than what we mentioned earlier. There are a couple of those developments, such as there's the, we were talking about re-enrollment. We know that they've shared some data with us about how folks are doing around the state, and most people seem to be doing fine. The vast majority of folks have managed to get their 6-month metrics in. We've talked in the past about the practices that require to submit remediation plans for not making the 6-month metrics, and that we haven't heard anything else since then. So if folks have more feedback about that, we definitely want to know about it. We have some information about upcoming events that we want to be able to present. And Kristen, can I turn it over to you, or Amy and Kristen, can I turn it back over to you for that?
Sure. For sure. Kristen, do you want to talk about yours, or do you want to talk about the forum as well?
I'll start, and then you can talk about the forum, if that's okay. We'll just be continuing with our monthly webinars, and we have our 2 upcoming in-person learning sessions. And if you have not already contacted me, please do to let me know if you're coming. We already have a bunch of people coming, which is wonderful. And again, it's on Friday, October 17th from 12 to 4 at ACH. Amy, I will turn over the rest of the meeting and the reception after, and the forum, if you'd like to talk about that for a minute.
Sure. So immediately following the forum, we are going to have our annual AAP chapter business meeting, followed by a reception to just kind of have an opportunity to do some networking and just visiting in an informal setting, and we'll have food and drink there for you guys. That will all be in the same room, which is Children's Hall at Children's Hospital, not to be confused with Chairman's Hall. So that is on Friday. On Saturday, for folks that want to participate in the learning session on Friday and actually want to stay over for Friday night, if you guys want to do that, you can join us for the Pediatric Forum, which will be held from 8 a.m. to 11:45 a.m. on Saturday morning. That will be in Chairman's Hall, not to be confused with Children's Hall, on Saturday morning. So Saturday morning's forum will be in Chairman's Hall on the ACH campus, and it will all be focused on oral health. We've got 3 hours of CME credit available to folks who attend, as well as we are providing an opportunity to complete the certification to become eligible to apply fluoride varnish in a clinic setting. Medicaid has approved that for reimbursement for primary care physicians and their staff members to be reimbursed when they apply fluoride varnish. So we'll go over the reimbursement code, the process for becoming certified, and get everybody well on their way to being able to do that application. So the one thing that the health department that is legislated is that the health department does require this specific certification to be complete by all people who actually apply the varnish. So it's free for AAP members, chapter members, and then there is a nominal fee for any other folks who want to come and do that certification and get CME. So we have a flyer that I can email to Kristen, and she can get it out to you guys, but you can apply, or you can register online at eventbrite.com and just search the Arkansas Pediatric Forum focus on oral health. And then, as always, I can be reached by email or via Kristen if you have any other questions.
Okay, thank you. And Dr. Crow, did you want to go over the 12-month requirements again?
Yeah, I think we pretty much covered it. I mean, basically, we will give more details about these metrics as we get closer, since we don't have to submit these until the end of December. But I think the main thing is to make sure that you're looking at joining SHARE if you haven't already. And we are inviting some of our colleagues to SHARE back in at October, so that's going to be in the agenda, and so that'll be a good opportunity to look at the components for implementing SHARE and what SHARE actually looks like. So I think that's all we need to do for that one. Kristen, next slide. And keep in mind that when it comes to a practice audit, it will help AFMC, it'll help our colleagues at AFMC if you're able to keep an organized notebook of your progress. So, as you mentioned earlier, it's really important for us to keep track of not only what we're doing, but if we have any specific results in changes that we made in our practices, that will help as well. We are recommending that you keep detailed documentation for how you identified your high priority beneficiaries. Keep your practice needs assessment handy. Look at what you're doing for strategies for care coordination and practice transformation, what you're doing to address medical neighborhood barriers, and what you're doing to address 24/7 access to care. And in general, it's just if you can produce a paper trail about activities, emails, or meeting notes or such, that'll help. If you don't have them, we recommend you come up with some way of just documenting the activities that you're doing internally, so that'll help out our AFMC colleagues when practice audits do happen. As I'm sure we are aware of, the way that they're going to we have to attest that care plans are being implemented, and they will in an audit asked to look at care plans for specific patients, so that's something to keep in mind. And I think that is it. Kristen, last slide. Are there any questions? It's almost 1:15. Any questions, reactions, concerns, things that we want to discuss before we end the call? Okay, so we are always available. Send us an email, give us a call if you have any questions, any reactions, anything that you're seeing. And I think because the next meeting would be October, we'll see you in October in Little Rock. So thanks, everybody.